Good morning. Do you mind if I start, Amelia?
No, go ahead.
Okay. Good morning, everyone. I'm Mike Farrell. I'm the supervising staff attorney for the Washington Medical Commission. And welcome to the Commission's Interested Parties meeting. The purpose of the meeting is to provide interested parties with an opportunity to have a conversation with Commission staff and maybe Commission members regarding topics that will be discussed at the upcoming meeting of the Commission's Policy Committee. The Commission wants to foster increased engagement with interested parties, the public, and licensees. We believe that this meeting and this process will provide better feedback for the Commission and provide an opportunity for you to have these discussions and provide comments and help the Commission develop better policies, guidance documents, and interpretive statements. The upcoming Policy Committee meeting is scheduled to take place on Thursday, January 4 from 10 to 11 a.m. That meeting will be virtual. I invite you all to attend that as well. You'll have to register for it, just like you did for this one. The Policy Committee will discuss these topics, and then they will make recommendations to the full Commission, whether to adopt or revise or to even rescind Commission policies, guidance documents, and interpretive statements. The next full Commission meeting is scheduled for Friday, January 19th from 9 to 11 a.m. That also is virtual. There are 3 items on the agenda today that we'll be discussing. The first item is the proposed rulemaking by the Department of Health's midwifery program. So that is in your packet. The proposed amendments to rules expanding the scope of practice for midwives. And at this time, I would invite Kathy Weed or anybody from the midwifery program to just give us a little background on this.
Thank you, Michael. Hi, everybody. I'm Kathy Weed. I'm the program manager for the midwifery program. And we're coming to you today, well, to discuss the changes that we've made. There was a bill in 2022 that added 2 license extensions for midwives. One is for a limited prescriptive license extension, and the other one was for medical devices and implants. We actually split that medical devices and implants license extension into 2 license extensions. So there would be a total of 3 for midwives. Per statute, we are required to collaborate with the Medical Commission and the Pharmacy Commission on the Legend Drugs and Devices rule section. And also we need to collaborate with the Medical Commission on the new section of the training required to obtain the license extension. So you'll see we have the entire chapter open that made some changes that were more inclusive and just cleaned up some language. So there's a lot of language here, but the 2 sections that you would be most interested in would be the Legend Drugs and Devices section, and then the new section again on the training required for the limited prescriptive and medical devices and implants license extensions. And welcome any other program people or licensed midwives that are on the call to add to that.
I'm certainly happy to try to answer any questions. I'm a licensed midwife. I am an assistant professor at Bastyr University. So we have a master's of science in midwifery that we, offer. So if I can be helpful.
Thank you. Can you provide us your name?
Oh, yes. So sorry. Kristen Efland, and I live in Central Washington, if that's helpful.
Thank you.
And I'm Deborah Gleisner. I'm a naturopathic doctor and a licensed midwife. And I worked on some of the draft language on this, and I'm also happy to offer a perspective from somebody who has both a midwifery license and a naturopathic license. So I prescribe some of these medications on a regular basis.
Hi, so this is Diana Curry, OBGYN on the commission. I participated a little bit in some of the discussions with the midwifery committee on these changes, and there was a lot of discussion back and forth about how many device insertions you have to do until you're qualified, or how many hours of CME for prescribing. So I don't know if it would be helpful for Kathy or one of you guys to maybe just quickly summarize sort of what we ended up coming to, like the decision that got put into this language of how many hours or how many devices, because I think there was so much discussion that it's worth taking a minute to just describe that a little bit and how we ended up where we are. Thanks.
It might be helpful if we could put up on the screen the rule sections for that, because if I try to do it off the top of my head, I won't do it well. So it might be on page 8 or something.
Okay.
If you could scroll down, I don't think I have control of anything.
And the scrolling will be very
Okay.
slow. I apologize.
So this is the section on the training needed for the license extensions. Maybe we could go back up just a little bit. Yes, thank you, section 165. All right. Oh, a little too far, a little too far. Maybe down just a little bit.
Sorry, I'm using a screen that is not like synced up to what I'm actually doing. So.
Well, and while you're looking for it, perhaps
Yeah.
I can, licensed midwives, have any number of requirements to get licensed in Washington State. We attend 100 births, do 50 pap smears, have, some pharmacology training, which, has enabled us to have a drug legend prior to now, where we can administer and obtain and administer a variety of medications that are used during birth if needed, or postpartum, like Pitocin for, postpartum hemorrhage. We, offer our clients antibiotics prophylactically for group B strep, that sort of thing. So that's sort of the basis of where licensed midwives in this state come from. And then, now what we're talking about is this license extension that was added to statute for midwives who want to get that additional training to be able to offer medications that are commonly used in pregnancy or postpartum if needed, such as, antibiotics for a simple urinary tract infection. Obviously, anything complicated or any concerns about pyelonephritis would be sent right to the emergency room. That's our job, right, is to do that risk assessment. So if that's maybe some helpful background.
Thanks,
Anyone else?
Kristen. Oh. So I was just gonna go over this real quick. So for somebody that wants a limited prescriptive license extension, they have to do an additional 15 hours of obstetric pharmacology. They would have to submit evidence of completion of additional training on family planning and treating common low risk prenatal and postpartum conditions. That could be a clinical experience of at least 20 cases reviewed in consultation with another licensed healthcare professional, or a clinical training course or courses approved by the department. And of course, we would work with our midwifery advisory committee to go over that. And the 15 hours we got to with some input from, let me look it up. So the ARNPs United of Washington State recommended a total of 13 hours, or I'm sorry, 30 hours. And what we decided was that in the existing midwifery training, just to get a license, they were already getting about 15 hours. So we bridged that gap, and that's where the 15 hours in the new language comes from. If that helps there. And then since midwives don't have a license, they can't go out, or like a license extension to prescribe, they can't go out and be doing the work. So that's why we put in there the clinical experience of at least 20 cases reviewed in consultation with another licensed healthcare provider for that limited prescriptive piece.
Billy Dixon, do you want to say something?
Yeah, I had some comments. I wanted to let Kathy finish running through the document if you had more to say, Kathy.
Well, I think I can stop there for the limited prescriptive piece. Well, I guess I can just say for the medical devices and implants, of course, there's going to be training with the manufacturer. There's going to be supervised simulations of insertions and removals, and then that insertion and removal in a clinical setting as well. So that would cover kind of that piece. And then the legend drugs and devices section is different. So just briefly, that's what it looks like. But go ahead, Billy.
Yes. Oh, thanks, Kathy. Good morning, everybody. My name is Billy Dickinson with the Washington State Medical Association. The WSMA has been working in collaboration with the Midwifery Advisory Committee as well as the Midwives Association throughout this rulemaking. Really appreciate Kathy and Kristen on this one. It's been a real collaborative process. We're really happy with how this draft WAC has progressed through the spring and summer. As noted in the letter we sent to the WMC on Wednesday, we do have an outstanding concern about the inclusion of, excuse me, I'm not a clinician, nifedipine. Nifedipine, okay. Nifedipine, as you know, is used to treat preterm labor or hypertension, both of which are outside of the prevention and treatment of common prenatal and postpartum conditions this rulemaking is specific to. We are concerned that this prescriptive authority in particular might jeopardize patient safety by delaying referral to a physician, the results of which may include significant hypotension, preeclampsia, or failure to get steroids necessary for fetal lung maturity. As the regulator of both physicians and physician assistants, we think it's prudent for the WMC to share their concerns on this item. And thanks for the opportunity to share. Appreciate everyone's work on this.
As a current prescriber of different medications, I want to say that using nifedipine as a for treating hypertension was never the intention of the way this draft was written. And you can see that it says specifically for preterm labor. But I also want to say that I would never be using this to be prescribing nifedipine instead of sending somebody into the hospital. I agree with you. The concern is that this person would need to be treated for their preterm labor in the moment and given appropriate medications. The only place that I would consider that this could potentially be used is in a place where somebody did not have immediate access to a place where they could get that triaging and treatment. And I'm constantly being reminded that we have to be thinking to ourselves not about the people who are in the greater Seattle area or the area that are very urban and have immediate access to medications, but places that are perhaps more rural. And I'm wondering, I wasn't part of the draft making that included nifedipine initially, but I'm wondering if nifedipine had been intentionally put in here as a stopgap means to try to handle a situation that might otherwise go untreated at all. Though I hear your concerns, and I don't think that nifedipine should be something that is prescribed by a midwife instead of being sent to an appropriately higher level provider or even a triage situation instead.
I also wasn't there when this was I think a last minute ad as we understand it. And so I personally wasn't especially attached to the idea, even though I've only practiced in rural and medically underserved areas. We're still in Bellingham and Wenatchee, we're still relatively close to medical services. So I would have never needed to have done that. I wonder that if it were to be left in, if the wording, right now it says nifedipine for preterm labor, I wonder about adding language like nifedipine for preterm labor, while arranging transport or something like that. If, you know, if there are rural midwives who feel really strongly that their clients are in danger of not getting what they need as they're trying to get them where they need to go, I wonder about some kind of language like that.
At the same time, this is not an emergency medication. This is not like terbutaline. So I do understand the concerns about just having it listed. And like Kristen, I'm not particularly committed myself and the people that I work with to keeping this in here if there are more concerns about it. So there it says nifedipine for indication of preterm labor. If somebody's going to read that and say, I'm going to give nifedipine and not refer to another provider and not refer to triage, that is inappropriate. So we could either change that languaging or, in my opinion, remove that particular medication entirely.
Dr. Curry?
Does anybody know when that got in there or who put that in? Because I agree, I don't remember seeing that before when we went through this document.
This is something that came up at the Midwifery Advisory Committee. I think it was in March. There was a lot of people that supported it. There was some opposition as well. So it's something that we grappled with. And I left it in here so that we could have these conversations moving forward with the commissions. So that's, yeah, it's some people really thought it would serve a good purpose, and some people have concerns.
I mean, we are allowing terbutaline, and it's used in the same sort of context as terbutaline. It's a temporary measure, a temporizing measure for patients who can't tolerate terbutaline, for example. So if it would help to just allay anybody's concerns to put in something about, you know, for temporary, you know, treatment until further management or whatever your suggestion was earlier, I thought was a good one.
Yeah.
This is Billy.
Oh, sorry, go ahead.
No, this is Billy from the Medical Association. Obviously, we need to see language, but are open to something around that regarding referral or some safeguards, but would obviously need to see language.
Yeah, I can look, and you know, we all could, I think, you know, on the pages historically with the language in the drug legend. I believe that there was some words around, you know, where we have magnesium sulfate, you know, again, the idea being for transfer of someone, you know, while in transport, awaiting the ambulance kind of thing. If someone has such high blood pressure, you're just concerned that it's worth it, right, to give it to them, you know, as the ambulance is arriving. And I believe the wording in the law used to say, or in the rules here, used to say something like pending transport, or yeah, I think we can come up with like the, you know, what we think is the best language there. I think that's really reasonable, and it goes right along with our statute. I mean, by statute, we are required to consult when there's a deviation from normal, right? And so, you know, for what it's worth, you know, we are required by law to consult when there's a deviation from normal. So I would hope people wouldn't mind adding in that extra language. I certainly don't mind. I think it's appropriate.
Sorry to jump in. If you look at K above with respect to terbutaline, you could just crib that language. You could, and also in this case, we're not advocating giving it for high blood pressure. It's being given for preterm labor. So that is a different indication, and that could get actually added into sort of the terbutaline sentence in K.
Yeah, I agree. Copying that language. Sorry, I couldn't see it there and didn't remember, but I think that makes sense. We've already had that language for years. To just copy that language below, I think makes perfect sense. And we certainly do have some midwives who are quite far out from services.
Kathy, this is Billy again. If you could send me an updated copy of this when we're done here today, I'll take it back to our folks and have them take a look at it.
Will do, Billy. Thanks. But
Thank you.
maybe Deb or Kristen could craft the language and send it along to me just to make sure that it's right, and then I can share it with Billy.
Thank you. Appreciate it.
Thank you.
And what's in the chat right now is the language. Thank you, Jennifer, for popping that in there. It says magnesium sulfate for prevention or treatment of peripartum seizures pending transport. So we could just say nifedipine for preterm labor pending transport.
Kathy, this is Mike. You haven't filed a CR 102 yet, right?
No, we're going to do that after we meet with the commission. So we'll be doing that after January 19th because we meet with the pharmacy commission in a couple weeks.
Okay, thank you. Any other comments on this issue?
Hi, yeah, it's Diana again. Sorry. I had 2 points I just wanted to raise to make sure that they're called out and that we don't get blindsided later on. And I think, Billy, are you representing the Medical Association Washington? Is that what I heard?
That's me.
Okay, yeah, thanks. So the one thing that a lot of back and forth discussion was around was the medications and therapy. So it's in, paragraph 4 on the page we're looking at. Medications and therapies for the prevention and treatment of outpatient conditions that do not constitute a significant deviation from normal. So that was ultimately the language we decided to land on instead of trying to like list out conditions or anything like that. So I just want to be really clear that that is the nod to, don't do it if it's a crazy case, which is what I think all of the doctors are going to worry about, right? The OBs.
Right.
So I just want to make sure that Medical Association was good with that. And the other thing that I wanted to call out to make sure everybody's comfortable with is under going down just a little bit. It's right now on the screen, it's the third or fourth from the bottom line where it says medications for SAB prevention and completion. So I believe we are just leaving it vague, and we are including then misoprostol and all of that, as well as obviously like progesterone or whatever we just, people are going to use. But I just want to be sure the Medical Association is also comfortable with that and has thought through that, because again, those are just things that potentially I could hear people getting nervous or, worried about.
Thanks for flagging that, Dr. Curry. I will, when I take the language, the new stuff we talked about today back to our folks, I'll raise that as well and get some additional feedback for the Medical Commission and the Midwifery Advisory Committee the next time we see you all. Does that sound like a good plan?
Perfect. Thanks. Yeah.
Thank you.
Any other comments on this proposed rule?
I don't know if it's helpful to, along the lines, of SAB prevention and completion. Obviously, there is some political concern in the world about, the use of misoprostol for abortions. And so we have access to misoprostol for postpartum hemorrhage. And this, the license extension would, potentially allow when a miscarriage has completed, but, still inside the body. So not actually completed, right? When it's begun, but not completed, it would, include that and progesterone, obviously, in the ways that it's indicated for prevention. And, in an area like where I live now, that can be really important. In a place, there are midwives who practice where there might only be a Catholic hospital that maybe isn't always willing to prescribe that for, a missed AB when someone, the baby doesn't have a heartbeat anymore and needs to complete that miscarriage. So I'm sure that's the thinking there, if that's helpful. I mean, you're all healthcare providers, so you know about this. I'm not talking to you about something you don't know, but I thought I would add that.
Yeah, also I was wondering, and I meant to say this before, are we allowed to have SAB as an abbreviation in there, or should we be spelling that out in this document?
Great question. We should likely be spelling it out.
I agree.
In which case, I wonder if we could, Oh, sorry.
I just said, I agree. And I had that exact same thought as we were reading through that today.
Yeah, it's a good question. And I wonder if the word miscarriage could possibly be used just because of the confusion in the public around medical words such as spontaneous abortion.
That was going to be my next recommendation. But I would say spontaneous miscarriage. Maybe.
Spontaneous miscarriage, yeah.
I don't know. Again, you're going to get people wigging out about terminology, but miscarriage is certainly preferable to the word abortion.
So are you saying just replace SAB with spontaneous miscarriage? Okay.
Yeah, actually, I wonder if you want to put incomplete miscarriage. Let me think. No, just put maybe just miscarriage. So use misoprostol for missed spontaneous abortions and for incomplete spontaneous abortions. Missed meaning that there's no signs of a miscarriage, that nobody's bled or anything. You've just discovered it's no longer got a heartbeat. And incomplete meaning there has been some bleeding or spotting, but there's still gestational products in the womb. So those are the sort of the technical terms in obstetrics. So maybe just put miscarriage. Keep it simple.
Will you repeat what you thought was appropriate so I can type that up for Kathy?
I was thinking out loud, and I think maybe just put miscarriage. Simple.
So medications for miscarriage prevention and completion. I mean, I agree with you. I feel like messing around with it too much all of a sudden puts it in different categories that we may not be thinking of. We're trying to prevent a miscarriage and we're trying to help complete a miscarriage. Those are the two things we're trying to do.
Right. I think just use the word miscarriage and see how that goes.
For what it's worth, I agree.
Any other comments or feedback on the proposed rules?
Do we want to talk about the device insertions and removals from the letter?
I feel like we came to an agreement on that with, well, that's too strong of a word, but I think we addressed a lot of Billy's comments in the letter. I don't know, Billy, if you reviewed that or.
Sorry, this is Billy again with the Medical Association. I don't think I've seen this draft. When you emailed me, Kathy, you had told me that you had addressed some of the concerns, but I don't think there was a new draft included in that. And I'm happy to take a look at that and get you guys feedback. This might not be the most appropriate forum to do that. I think there'll be an opportunity to engage further at the policy meeting as well as at the Midwifery Advisory Committee meeting. But yeah, when you share the new draft with me, when you have a chance to make those updates, I can take a look and I'll be happy to share with y'all and the medical commission if our issues have been resolved.
No. So yeah, sorry I didn't include the language, but I think I just copied the language that you had suggested with the supervised. I don't remember if they were implants or insertions, and I think I just copied what you said.
Insertions and removals, what I saw in that letter, which looked totally appropriate.
Thank you.
Okay, anything else before we move on to the next document? And thank you, Kathy, and everyone else for your comments and feedback on this. Appreciate you coming today and participating.
Yeah, and thank you for having us.
And I hope you all can come to the policy committee meeting on the 4th.
Yes, thank you so much.
Okay. Okay, the next document is a current guidance document when the commission adopts a guidance document or a policy or an interpretive statement, they review that document every 4 years. This document, I believe, was adopted back in 2017. It was revised substantially in 2020, and we're at the 4-year review. I don't believe anybody has raised any big issues with this document since it was adopted in 2020. We get lots of questions about this document, about medical records. It's a big issue. So I invite any feedback on whether this document needs to be updated or revised or changed, or any issues that we have missed that could possibly be added and make this a more useful document for licensees. I welcome any feedback.
Hi, my name is Kara Helmer. I'm from the Washington State Hospital Association, and this isn't necessarily feedback. I did notice that the guidelines for retention of documents, they seemed to be at least partially based on the laws for retention that only apply to hospitals, which there's currently a law that's based on the patient's last date of encounter or discharge, which says that hospitals have to retain records 10 years following the last date of encounter or discharge. I just wanted to note, and yeah, I think it's kind of a bit down there. There it is. So 10 years from the date of a patient's last visit is kind of parallel to what the hospital's actual law is. I just wanted to note that we are looking at simplifying that a bit for hospitals, because that can be a bit complicated in terms of if patients don't necessarily tell us, oh, we're not going to see you anymore, and knowing when they were last there can sometimes be difficult. So instead of keeping their records together and figuring out when they actually were last there, we are proposing to make the rule the same for minors and adults, and just say medical records shall be kept for a minimum period of 26 years after discharge or date of encounter. And that's not the last time that patient was seen, it's the last time that the date of that medical record. So it doesn't necessarily, I mean, this law doesn't apply to clinics, but I just, since this seems to be based on current law, I just wanted to note that.
Okay, Amelia, can you scroll down so we can see the footnote? And Kara, are you referring to in the footnote 7041-190? You mentioned rule. Is there a rule in addition to the
no,
statute?
there's not a rule. It's RC statute. Yeah, sorry.
Okay, all right. And you're proposing that this 7041-190 be revised to address the issue you just mentioned?
I believe, let me pull that up. 7041-190 is the one that applies to hospitals. And that's what we are, this coming session, proposing and a revision.
Okay, thanks. Good to know. So the statements in this document and the footnote is still accurate. It's just, this is just an FYI that statute may change, right?
Yeah, this is just an FYI that statute may be updated in the next,
thanks.
6 months or so.
Okay, thank you.
And since it doesn't have to be based on that statute, the reasoning for the update of that statute, it may be something to think about.
Okay, thank you. Any other comments? And by the way, if you have comments, if you think of something later, you can just email me, preferably before January 4th, so I can bring your comments to the policy committee meeting. Any other comments or feedback before we move on to the last issue? Okay, let's go to the last document. Like the previous one, this document hasn't generated a lot of feedback over the years, but it was first adopted back in 2016. It was reviewed in 2020. The commission reaffirmed it, and now it's up for its 4-year review. So this is processing. It explains how the commission processes complaints against licensees who are enrolled in WPHP. And the purpose is to provide some type of structure and order and consistency to commission decision-making, and some consistency and a little bit of certainty for the WPHP and for licensees and for the public. So that's the purpose of this. It very generally goes through the commission's view on physicians who are in the WPHP, and sets forth some general principles about in what cases, in what circumstances the commission would take action even against someone in the WPHP, and in what circumstances they would perhaps not take action against somebody who's in the WPHP, who's compliant and is not a risk to the public. There is a gap that was identified by one of our attorneys. As the document points out, there's a statute which allows a disciplining authority. Amelia, if you could scroll down to just a little bit more. There we go. Up just a little bit. 18-131-75 is an important statute because it allows the disciplining authority to make a referral to a substance use disorder monitoring program, such as the WPHP, in lieu of discipline. And that's a judgment call in each case by the disciplining authority, in this case by the medical commission. And somebody said, the document does not address the situation in which a referral is made and the WPHP concludes that there's no issue. Maybe the problem was episodic and the person does not need to enroll in the program, does not need further evaluation. So I'm going to propose to the policy committee that we add language just addressing that, because it assumes that the person is going to enroll in the WPHP, and that doesn't always happen. And Dr. Chris Bundy is here. If you want to add anything to the comments I just made, or perhaps even comment on the frequency in which that occurs, that the commission or some other board refers someone to your program, you do an assessment, and you see no reason for further evaluation or enrolling in the program.
So I guess I don't need to raise my hand if you're calling on me. Thanks, Mr. Farrell. It's a pleasure to be here, and thank you to the policy committee for hearing my comments. I just sent you by email some edits for the policy committee to review and for you to review. It doesn't address the issue that you're raising now, but it addresses really some language updates, some preferred terminology. It's really just housekeeping for the most part. I don't think most of the changes that I recommended are substantive. It's using terms like adherence rather than compliance. It's from changing contract to agreement. We don't make contracts with our program participants. We have voluntary health support agreements, using the term health support agreement rather than monitoring. We're kind of moving away from some of those terminologies. But really, there's also, since the last iteration of this, there have been substantive changes to 18-131-75 that one refers to as not as a, it does identify substance use disorder monitoring programs, but we're actually specifically named as a physician health program, and there's a difference. So we would prefer that terminology be utilized here, as well as there are lots of places in this document that call out or differentiate physical from mental health conditions. We actually believe that that's stigmatizing, and so in every instance of that, we would ask that the commission adopt the term health condition, which is all encompassing and reflects the scope of WPHP. So similarly, things like unprofessional conduct that may be the result of substance use disorder. Yes, it's true that in the past 18130, 175 called that out, but that was actually one of the main reasons we went to the legislature, was to broaden that to all health conditions that WPHP can assist with. So we've just made some language changes in with all of that, and I'm happy to work offline with the policy committee if there are any questions or concerns about any of those language changes that I've sent your way. But mostly it's to harmonize with 18130, 175 and just provide some updates to preferred terminology. Relapse is no longer the preferred terminology in the addiction treatment world. We talk about return to use rather than relapse for reasons that I won't bore you all with right now, but it is considered less stigmatizing to talk about return to use than to talk about relapse. So just all of those pieces are kind of incorporated into the feedback that I've sent you for your consideration. And then to your question about this more substantive change, I would say that on the licensing side, it's more common for us to find no concern for impairment and endorse someone. On the disciplinary side, I think it happens, but I think it's pretty unusual. And in cases where it might happen, these cases might involve professional sexual misconduct or boundary violations or other things where, yes, an impairing health condition could be part of the picture, but we ultimately decide, no, there's no impairing health condition here, and the commission should proceed, as it were, with its disciplinary process, and without consideration of impairment as a contributor to one of those issues. But that's pretty unusual. On the discipline side, there's usually stuff there that's going to increase the likelihood, if you will, the prior test probability that somebody referred to WPHP is ultimately going to be found to have an impairing health condition and need monitoring. But I agree that there might need to be language in here to capture those exceptions.
Okay, thank you. I got your email. I tried to put it in the chat. For some reason, it just won't go. But if anybody wants it, please let me know and I'll forward it to you. Any other comments on this? And I'm going to make those changes, Dr. Bundy, and send this out. So it's updated and consistent with the statute. And if you don't mind, your letter will be part of the packet for the policy committee meeting. Not your letter, but your email with the attachment and proposed revisions, in addition to my new draft.
Perfectly fine. Thank you.
Okay. Thank you. Any other comments before we adjourn? Okay, this is a wrap. Just to remind you that the policy committee meeting, that all these comments today are going to be forwarded to the policy committee. They meet on January 4. That's a Thursday from 10 to 11 a.m. The full business meeting by the commission is January 19 from 9 to 11, I think. Those are virtual. We invite you to attend those meetings as well to provide feedback. If you want to provide feedback directly to me. Okay, I have a question here. Where are public comments? Okay, Amelia, can you put the link to the policy page in the chat?
Yeah, hold on just a second.
We have a page on our website, policy page, that allows you to put in comments, and there it is. And thank you. So if you want to submit comments, you can do it that way, or you can send them directly to me. And I'm going to put my email in the chat. Any other questions or comments? Okay, then we're going to conclude the meeting. Oh, there's a hand raised. I'm sorry. Bob R.
I'm sorry, my name is Bob Runnels with Informed Choice Washington, member of the public, basically, for the purposes of this meeting. I thought there was going to be open public comment during this meeting? Or did we miss the moment?
Go ahead. You can make a comment.
Thank you. Yeah, so I'm Bob Runnels, Director of Informed Choice Washington. I'm speaking to the topic of doctor licenses being challenged by application of the Federation of State Medical Boards letter that was issued during the pandemic, threatened disciplinary action if doctors perform their jobs, contrary to the one standard of care declared by the CDC. The notice provided by the WMC is self-contradictory. It begins with the WMC position on COVID-19 prevention and treatment is that COVID-19 is a disease process like other disease processes. But every authority on the matter labeled SARS-CoV-19 as novel. Therefore, the disease needs doctors to bring to bear all the available information to treat a novel disease. The public sees through what is being done here and challenging doctors for speaking off the COVID narrative that's provided by recommended by the federal level agencies. And we really do not, we see it as egregious that the WMC would act as a tool of public health when they should be supporting doctors in their individual practices. Thank you.
Okay, thank you, Mr. Reynolds. We do have, this meeting is intended to address the items that are before the policy committee meeting, but I want you to know that there is a public comment period for the commission business meeting that you can make those comments. I think you're limited to 2 minutes during the business meeting, but you can make those comments again then.
Thank you very much.
Okay, anything else? Then this meeting is concluded. Thank you very much for attending and participating. I think these meetings are very valuable to the commission, and we appreciate your feedback and comment. And the next step is for the policy committee meeting to meet on January 4. Thank you.